On. Okay. Hi everyone, good evening. I will introduce myself first. My name is Hedieh Arshiany. I'm a psychiatrist. I've graduated from Tehran University of Medical Sciences last year. Presently, I work in private practice and I'm going to talk about mood disorders today. So I'll just share the screen so you can have my slides. So the first question is generally, what is a mood disorder anyway? Basically, mood disorders are conditions where emotions are derailed and dysregulated for an extended period of time. Please, if I'm talking fast or slow or whatever, please say something. The main types of mood disorders are bipolar disorder type 1, bipolar disorder type 2, and cyclothymia. These three are mainly categorized as bipolar affective disorders, and other two, meaning unipolar depression and dysthymia, are categorized as depressive disorders. So if we just look at mood disorders as a continuum, we can place mania or the very high mood at one end or pole of this continuum, and the very low mood or depression at the other end of this continuum. So this is why we call it a bipolar disorder. And all the other disorders are placed somewhere in between these two states. So we'll just have a quick review on the epidemiological statistics of mood disorders. According to the major WHO surveys, the lifetime prevalence of bipolar mood disorder is about 1%. Other researchers and studies have found out that bipolar mood disorder type 1 has a prevalence of 3.3 and type 2 has a prevalence of 1.1% over the course of lifetime. For MDD, this ranges from 8 to 21% in different countries with the average of 11.1. This means 1 out of every 10 people will experience major depressive disorder at some point during their life. About the gender differences, unipolar depression is much more frequent among women than men. The most pronounced difference between the two sexes is between the ages of 30 to 45, but in bipolar mood disorder, there's a more equal balance between male and female, it's 1-to-1. The more the depressive components, the higher the proportion of women. Even in bipolar disorder, when there's a mixed episode or depressive episode, there will be a higher proportion among women till when there are only manic symptoms present. So the next part is, when a patient is manic, how do they present themselves in the clinic? A manic patient usually has an expansive, elevated, or irritable mood. The expansive and elevated mood is very infectious. We can feel it. They make us feel happy and joyful when they enter the clinic and when we do the interview with them. The irritable mood is usually present when they want to carry out a plan and we prevent them from carrying out the plan because they have a very impaired judgment. The impaired judgment makes them act on the desires they have, like they might have very harmful plans for themselves. They might do dangerous things. And when we try to stop them, they become irritable. This may lead to verbal and physical aggression too. They also are very talkative. They have loud and pressured speech. It's very hard to interrupt them. The content of their thoughts is elevated self-esteem. They have grandiose ideas. And also they experience cognitive impairments. They are very easily distracted. They can't concentrate on anything. Also, they experience a decreased need for sleep, they are hyperactive, they have excessive energy. Their judgment, as I have talked about it, is impaired. So they might engage in very harmful activities and dangerous activities, like, for example, promiscuous sexual activities or pathological gambling or very idiotic investments, and they might cause financial disasters too. They also act disinhibited. They might go out in social situations with very inappropriate clothings. They may also experience delusions and hallucinations. I'm not sure whether you're accustomed to the terms, but delusions means any false, fixed idea that is not related to cultural beliefs. It's a fixed, false idea. So they have delusions of very great amounts of wealth or power. This is quite seen in about 75% of the patients. The next part is about the clinical presentation of a depressive episode in a bipolar patient. It is very, very similar to the depressive episode in a depressive disorder, so we'll talk about it later. The major importance of this part is that differentiating a unipolar depression is very important to be differentiated from a bipolar depression, because the treatments we generally use for unipolar depression may exacerbate the course of the bipolar patient. They may cause rapid cycling, or they may cause a manic switch to happen. So it's very important to differentiate these two from each other. Now, how can we do this? If a patient has a history of a manic episode or of a hypomanic episode, we can easily categorize the patient as a bipolar patient and treat his depression as a bipolar depression. But in the absence of such a clear-cut manic episode, we can use indicators, such as frequent depressive episodes with very short durations, like 5 or more depressive episodes which each last for less than 3 months, or atypical symptoms, or postpartum onset. These are just indicators. They don't mean the patient is bipolar, but they make us pay more attention and consider an underlying bipolar disorder. So the next part is, how can we diagnose a bipolar disorder type 1? The most essential part for this diagnosis is to have at least one clear-cut manic episode or mixed manic episode. The criteria for a manic episode includes this. The patient needs to experience an elevated, expansive, or irritable mood that persists for at least 1 whole week. And during this 1 week period, at least 3 of the following symptoms must be present. The first is an inflated self-esteem or grandiosity. The second is a decreased need for sleep. The patient may be able to function normally even after 3 hours of sleeping. The third will be a pressured speech, or the patient will appear more talkative than usual. He will experience flight of ideas or racing thoughts. He will change through subjects very rapidly. We can't even catch what he's talking about. The fifth will be distractibility. He cannot concentrate. It will be easy to distract him. The sixth is psychomotor agitation or increase in goal-directed activity, such as sexual activity. And the seventh is excessive involvement in activities with potential harmful consequences. They cannot predict or judge these harmful consequences, so they get involved in them. In addition to the symptoms I mentioned, the symptoms should be severe enough to cause marked impairment in social or occupational functioning, or they may be severe enough to require hospitalization for the patient, or the patient might have psychotic features. The fourth criteria needed is that the episode must not be attributable to the use of a substance or another medical condition. So if the manic episode has started after amphetamine use, we cannot call it a manic episode or a bipolar type 1 disorder anymore. The second disorder is bipolar disorder type 2. The main difference with the bipolar disorder type 1 is that in bipolar disorder type 2, manic episodes don't exist. The patient has never met the criteria for the full manic episode. Also, there has to exist episodes of major depressive disorder. This is not a necessity in the bipolar disorder type 1, but in this one, major depressive disorders must be present. Also, there are one or more hypomanic episodes, and the function of the patient is often preserved. Cyclothymia is another disorder in this group. It is milder than the two last disorders. Neither complete episodes of mania nor major depressive disorder are present in cyclothymia. It has a very chronic course. It lasts for at least 2 years. The symptom-free episodes go on for less than 2 months, meaning that the patient goes on for 24 months of having symptoms, and in the middle, only 2 months of symptom-free euthymic mood is present. So there are numerous periods with hypomanic and depressive symptoms, and they are present for the majority of the time. The criteria of major depressive disorder and mania have never been met. We'll talk a little bit about the course of bipolar disorder type 1. The age of onset is in very young ages. It starts about 20 years of age. Usually the first episodes are depressive episodes. 4 or 5 episodes goes on before the manic episode starts. The switch from depressive episodes to manic episodes occur about the age of 30. And only about 20% of patients go on experiencing just manic episodes without any depressive episodes coming about. Also, the onset of the manic episodes is usually very rapid. They start during hours or days. Sometimes they might go on about a week. The onset might go on for a week. Untreated episodes last for 3 months, but if treatment is used, then 1 month the episode will finish and end. Bipolar disorders are very chronic disorders. Most of the patients, about more than 90% of them, experience recurrences and relapses. This is why that they cause a large amount of impairment. Also, rapid cycling means that more than 4 episodes has occurred during the last year, and this is the case in 5 to 15% of patients. Bipolar disorder type 2 has a more stable course of disorder. I mean, the diagnosis does not change usually after 5 to 15 years. It's a chronic disorder. It's a chronic disorder and it requires long-term treatment strategies. Usually psychotherapy needs to be added to the medication treatment. Bipolar disorder has a poorer prognosis than major depressive disorder. As I have mentioned, more than 90% of patients experience recurrence of symptoms. One-third of patients will acquire chronic disorder. Should I continue? Is there any questions here? Okay, so there are some prognostic indicators that can show and predict whether bipolar disorder will move to a good prognosis or a bad prognosis. If the manic episodes have a short duration, if the few, and if no comorbidities exist, these show a good prognosis of the disorder. Also, a higher age of onset can indicate a good prognosis. A A bad prognosis will occur if the patient has a poor occupational status, alcohol dependence, depressive features exist, or psychotic features are present, or there is a male gender. I think someone's microphone is on. Should I? There's some background noises. Okay. So for the treatment of bipolar disorder, because I've been informed that most of the audience are medical students, I don't know how much in detail you want to talk about treatments or medication in bipolar disorders, but I just outlined the main treatment guidelines. The first step in treating a bipolar disorder is determining whether hospitalization is needed or not. In cases of severe mania, when aggressive treatment is recommended, it's better to hospitalize the patient. Also, when the judgment is grossly impaired and when there's a risk of harm to the patient or to others, or when the patient will not comply to using the drugs or physical aggression is probable, these are the preferable cases for hospitalization. So in these cases, we will consider hospitalizing the patient. Um, the next point is that in all mood disorders, if pharmacotherapy is combined with psychotherapy, the treatment is enhanced. So this is the second thing that we'll do. We'll combine the two treatments with each other. And the treatment phases are divided to acute phase and maintenance phase. For treating acute mania, the most important drugs that are used are mood stabilizing agents. Lithium is the most popular and most common mood stabilizing agent that is still used. But because of its delayed onset of action, it could be usually added with atypical antipsychotics or high-potency benzodiazepines to have a more rapid onset effect. So, a normal regimen for an acute mania would include lithium plus an atypical antipsychotic and a high-potency benzodiazepine. At least this is the way we treat our patients here. The treatment of acute bipolar depression is much more complicated and the results are less satisfying. Unfortunately, many patients don't respond very well to medications, but still reports are that lithium, lamotrigine, and quetiapine make very good responses. And patients achieve a very good symptom reduction. Lithium combined with lamotrigine is the main treatment that is used here. The next phase of treatment is maintenance treatment. All mood disorders need maintenance treatment after the acute phase is over. Maintenance treatments will continue because relapse rates are very, very high, and the only way to prevent recurring mood episodes is using maintenance treatment. We can use either lithium, valproic acid, carbamazepine alone or in combination with other drugs. Usually, the drug that has been used for the acute phase will be continued in the maintenance phase of treatment too. So if there are any questions about bipolar disorder, we can have a break right now, or we can move on to depressive disorders. Doctor, you have raised your hands. Can you ask your question? Okay, so I see the president of the Indian Psychiatric Society has joined. I'm very pleased to be in your presence. Welcome you. And I see questions here versus well. Well, usually for the manic episodes, we prefer to use lithium. Lithium is our very first use, especially if the patient is a young woman. We usually try to avoid valproate very, very much because of the pregnancy and the complications it may cause to the baby. And but because of some places maybe where laboratory testings aren't available and lithium has a very narrow lethal index, we can't use lithium if there isn't enough, um, if we aren't able to do laboratory testings regularly. So it's very, very up to the situation and circumstances that we are in. Lithium is usually considered the first choice in manic episodes. But if laboratory testing isn't available, we can use valproate as well. And of course, valproate starts onset of action is more rapid than lithium. Lithium will start about 7 days after administration has started, but we can use valproate with a loading dose, and so it has a more rapid action, maybe 3 to 5 after it has been started, sometimes even earlier. And about mechanisms of action of lithium in the CNS right now, I don't have in my mind, so sorry about that one. And what is the main difference between major depressive disorder and bipolar 1 disorder? Well, um, bipolar 1 disorder is categorized by a complete episode of manic episode, a complete mania has to happen for the diagnosis of bipolar 1 disorder. If this happens, the diagnosis of major depressive disorder will be included. Inclusion for MDD if a bipolar episode has occurred. In bipolar 1 disorder, major depressive episodes will occur. MDD, the abbreviation for major depressive disorder. The disorder is completely different from the depressive episodes that occur in bipolar 1. I don't know if I've answered your questions or were they clear enough? The indication of carbamazepine of bipolar disorder. Well, carbamazepine is actually a second-line treatment in mania. It can be used in some places line treatment. They are we have some there are some tables, first line treatments, second line treatments, and third line treatments in all of these disorders for the acute phase and for the maintenance phase. Um, uh, because I'm not sure about the audience and what I mean, if you're general practitioners, then maybe not very important to differentiate these treatments, but we have strict tables and guidelines that what treatment should be started and what's the next level and what we should change it to. So lithium and valproate sodium are more preferable than carbamazepine, but carbamazepine can be used too, whether in combination with lithium. With sodium valproate, it's not very useful, but it can be used in combination with lithium. Um, Mainly, we use it when the patient hasn't responded to lithium or sodium valproate, or because of side effects or drug interactions, we are unable to use lithium or sodium valproate. Generally, the most time we use carbamazepine. Or if the patient has epilepsy and is on carbamazepine for another indication, then we just adjust the dose. So both disorders can be controlled with carbamazepine. I hope. That's explanation for your question. The question about major difference between MDD and bipolar 2. You're welcome. Bipolar 2 disorder needs to have a hypomanic episode. It's different from MDD in this way. Actually, it's different in MDD in two major ways. MDD is an episodic disorder, has intervals of euphoric episodes, and although its course is chronic too, but bipolar 2 disorder is very, very much more chronic, and it is impairing, very, very much impairing. But bipolar 2 disorder patients experience hypomanic states too as well. I mean, a very important criteria that needs to be met. So if there's only a major depressive episode, the diagnosis will be MDD. But if it sometimes switches and changes with elevated moods higher than the euthymic mood and hypomanic episodes occur, then the diagnosis will change to bipolar disorder type 2. So these are questions. You're welcome. So we'll talk about depressive disorders. The main manifestations of depressive episodes are, first, it's dysphoria. Dysphoria is a sense of sadness, feeling blue, feeling down. The second is anhedonia. This is when the patient loses interest, pleasure totally in everything that was joyful for him till that point. Some patients don't actually present with dysphoria or anhedonia, but they present with somatic pains and somatic complaints, such as physical pain, headache, pains in the arms, in the shoulders. This is actually very common. The appearance of a depressed patient is like this in extreme cases. They have stooped postures, they are bended forward, they have a downward gaze, and they move very slowly. The time that it takes from them to enter the room, to sit down on the chair, will be a long period. Their speech has a low rate and a low volume, and they are very delayed in answering your questions. They also may experience neurovegetative symptoms such as fatigue, low energy, insomnia, loss of appetite, loss of libido, and even their sexual performance decreases. The content of their thoughts is something opposite to patients of mania. They lose their self-esteem and self-value, and their content of speech is all about self-blaming and guilt for inappropriate things. They don't like social interactions, therefore they have social withdrawal. Also, they experience suicidal ideations about in like more than 60% of cases, 2/3 of patients have suicidal ideation, and about 15% of patients attempt suicide. So one very, very important point in patients that present with a depressive episode is assessing the suicide risk. Now, it's out of the scope of this presentation, but many factors need to be considered when, like last and previous suicidal attempts, any psychiatric or medical comorbidities, the social status of the patient, if he's single, even if he's divorced, assessing his social support. These are very, very important matters in suicidal ideation. Anxiety, hopelessness, helplessness, these can all increase the risk of suicide. Also, these patients may experience delusions and hallucinations, or they may experience psychotic depressions. For us to make the diagnosis of major depressive disorder according to DSM-5, these criteria should be met. At least 5 of these symptoms must be present for the same 2-week period. 1 or 2 should be present. First, depressed mood, and second, loss of interest or pleasure. This is anhedonia, as we spoke about. Other symptoms include decrease or increase in appetite or weight. About 5% of the weight during 1 month is required for this third symptom. Insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, feelings of worthlessness or excessive or inappropriate guilt, decreased concentration or thoughts of death or suicide. Also, the severity of the symptoms should be enough to cause clinical significant distress or impairment in social or occupational functions or other important areas of functioning. Also, the symptoms should not be due to substance or another medical condition, and other psychiatric disorders shouldn't be better. They shouldn't explain the symptoms better than MDD. Also, no history of manic or hypomanic episodes must be present, because if manic or hypomanic episodes are present, the diagnosis will change to bipolar type 1 or bipolar type 2. DSM defines some specifiers for depressive episodes like melancholia, atypical symptoms, catatonic features, or postpartum onset. These may quite predict the course of the depressive episode. They're not very important, but it's good to know about them. Melancholia is severe anhedonia, early morning awakening, weight loss, and profound feelings of guilt. So a melancholic patient usually experiences a more chronic disorder, and it's called endogenous depression because endocrine metabolism also changes dramatically in melancholic depression. Atypical symptoms are when neurovegetative symptoms are reversed. Instead of a low appetite, overeating and oversleeping are present in these patients. Also, these patients are usually they usually have an underlying bipolar disorder, or at least we have to keep it in our mind that this might be the case. Catatonic features like stupor, blunted affect, extreme withdrawal, negativism, or marked psychomotor retardation, these usually show a more severe depression. Usually patients with catatonic features need to be hospitalized. You can't treat them outpatiently. Postpartum onset is too usually an indicator of a bipolar underlying disease. Now, the next disorder is dysthymia. The topic dysthymia doesn't exist right now in DSM-5. It is replaced and substituted with persistent depressive disorder. So when we're talking about its criteria, we'll refer to it as persistent depressive disorder. It has a chronic course. It lasts for at least 2 years. It has an early onset from childhood or early adolescence. It's less severe than MDD. The full criteria of MDD might not be met during the full 2 years, but impairment is much greater due to its chronic course. The criteria for it is that symptom-free intervals will not exceed 2 months. Criteria of major depressive disorder may be present at any time or even during the whole 2 years. The patient has never experienced a manic or hypomanic episode. Cyclothymia criteria is never met either. This one means that if a patient only experiences depressive symptoms sub-thresholds of MDD, it is called dysthymia if it persists for 2 years. But if somewhere in between the patient experiences hypomanic symptoms, even if they are not very, very extreme, like they don't reach the threshold for a manic episode, then cyclothymia will be the appropriate diagnosis. So it's like this. If there is hypomanic episode with major depressive episode, then the disorder will be bipolar type 2. But if the symptoms are lower than major depressive episode, then the diagnosis will be cyclothymia. If no hypothymia exists, then the disorder will be dysthymia. I hope this is clear. I can explain it further if you have any questions about it. And the last criteria is that drug abuse or medical conditions do not explain the disorder better than dysthymia. We also have other depressive disorders too, like minor depressive disorder. Minor depressive disorder has an episodic course of disorder, unlike dysthymia, which is a chronic disorder. But in each episode, the symptoms are less severe than a major depressive episode. 5 full symptoms will not be reached, like 4 symptoms, 3 symptoms will be enough. But the duration of the disorder will still be the 2 weeks. The second disorder is recurrent brief depressive disorder. In recurrent brief depressive disorder, the duration is less than 2 weeks. But in each episode, 5 criteria of depression are met. It means the severity is as severe as MDD, but the duration is less than 2 weeks. And the last one is double depression. Double depression is when an episode of major depressive disorder is superimposed on dysthymia. So the disorder goes on for 2 years, dysthymia's criteria is met, and then somewhere in between, the criteria of major depressive disorder is met too, and that's when it's called double depression. Okay, so after being able to name the disorders, now we go to the treatment. The treatment goals of unipolar depression, like bipolar, first is keeping the patient safe. Second, diagnostical evaluations may be needed because many medical disorders or many different medications can cause symptoms similar to depression. And the last part is initiating treatment, short-term and long-term, both need to be considered. So which patients do we consider hospitalization? If a patient has a risk of suicide or homicide, if he has reduced capability of providing food and shelter, or if multiple diagnostic procedures are needed, or if his support system has ruptured, or if he has a history of rapidly progressing symptoms, these are the 5 indications that hospitalization become necessary. Like bipolar depression, pharmacotherapy can be combined with psychotherapy to achieve more lasting effects and causing less relapses. The next part is choosing an appropriate antidepressant. We have different classes of antidepressants. The most important thing that we should realize and recognize is that different classes do not differ in their onset of action, in their general effectivity or efficacy, and also long-term recovery is the same with all classes of antidepressants. So what's different about them? The most important thing is that their side effects and their drug interactions are different. So because their side effects and their drug interactions are different, so we have to choose according to the patient's underlying diseases or comorbidities or tolerability of the different classes of antidepressants. We'll talk about the classes a bit later. Our goal of treatment is complete symptom remission. Symptom reduction will not suffice because if there's residual symptoms, relapses will be more and more severe. So why do treatments fail? The most common reason for treatment failure is that the physician is using too low doses for too short periods of time. So we have tables of the optimal medical doses which should be adjusted for the patients. And also the enough time is about 8 to 12 weeks for reaching the optimal dose of a efficacy of a medication. We usually start our drug trial with second or fourth generations of antidepressants, which include selective serotonin reuptake inhibitors, which include fluoxetine, sertraline, citalopram, escitalopram, or serotonin norepinephrine reuptake inhibitors like venlafaxine, duloxetine, desvenlafaxine, or newer drugs such as vilazodone, vortioxetine, mirtazapine, bupropion, and so on. These can be, either of these drugs can be used as the first-line treatment. Each should go through a drug trial, and a rule of thumb can be this, that at week 3 or 4, we expect a reduction of about 20 to 25% of the pre-medication symptoms of depression. So if after week 3 or 4, 20 to 25% of symptoms have not reduced, then we can consider using another drug. We can choose the second drug from the same class, or we can change the classes too. So if you're using fluoxetine as the first-line treatment and the patient hasn't showed enough response, you can change it to sertraline. It doesn't make a difference whether you change it to sertraline or venlafaxine or whatever else drug. TCAs are usually considered after a few of these first-line drugs are used because of their side effects, because of their cardiac side effects. Treatment failure is only considered when a drug has been used for 8 to 12 weeks and no remission has been seen. About the duration of treatment and prophylaxis of unipolar depression, I must say that the least duration of treatment must be at least 6 months or as long as the duration of the last episode. Whichever is longer, the duration of the acute phase treatment should be this much. And prophylaxis must go on. Prophylaxis must be continued for at least 6 to 24 months or even more, especially in patients who have experienced psychotic depressions or recurrent depressions or depressions with suicidal ideations or depressions which have caused occupational impairments. These are the cases which we continue the maintenance therapy for a longer period of time. And as for the last slide, the most important thing about I want you to remember from this presentation is that depression doesn't always mean unipolar depression. So when you're going to assess a patient which is presenting with depressive symptoms, always remember to ask about the symptoms of mania and hypomania. And if the patient shows any indications, you have to start the antidepressant medication with very, very low doses. It has to be titrated very, very slowly and under observation, because the patient might be a bipolar patient. So you might cause a manic switch in the patient, or you might cause a rapid cycling in the patient. Just keep it in mind that depression might be a bipolar depression. And the second message is that suicidal risk assessment should be taken very, very seriously. So in every patient presenting with depressive symptoms, you should ask about suicidal ideation, suicidal plan, and any previous attempts. The next message is that in all mood disorders, maintenance therapy is as important as the acute phase treatment. So drugs must not be discontinued after the acute phase is over. And the last point is that psychotherapy could enhance the treatment results, and so it must be added to medication therapy. Thank you for your attention. If there's any questions, I can answer you. Okay, so are there any questions? I would like to hear about your experiences in India. Are there any differences? Do you treat the patients in any different way or with any different algorithms? So there's no questions? No comments? No, sorry, I don't have your voice. No, unfortunately, I can't. I think you're on. And in Iran, in pediatric age group for mania, we mainly use lithium. Sometimes as a typical antipsychotic, we use aripiprazole instead of olanzapine or risperidone. Aripiprazole is usually the choice. Carbamazepine and sodium valproate are very less frequently used. And for depression, in Iran, we use fluoxetine very more commonly than other groups. SSRIs are TCAs, only apramine, other TCAs are never used. And sertraline is quite frequently used too, but the other algorithms are quite the same as adult population. Is it okay right now? I think you're unmuted. Okay, if there's no comments, no questions.
Yeah, can you hear me now? Hello? Hello?
Yes, I can hear you now.
Yeah, okay. So I'm sorry, I think there was some technical problem. So I would welcome Dr. Arshiany to CAV Foundation. We are basically a public policy and mental health think tank. We work in India with doctors, psychiatrists, and psychologists. And as we all know, we are conducting a number of webinars on issues of mental health. So I'm very grateful for Dr. Arshiany for giving her time, and hopefully we can invite her to India for a webinar or for conference, because we have a psychiatry hospital here. Dr. Ashani was asking about the protocols which we use in India. Well, basically in India we have uh, hospitals where there are large number of patients. Like in a typical OPD, we have 500 patients a day. So we do not have so much of history taking in depth. Like we can devote maximum 5 to 10 minutes per patient, but we follow the Mojni guideline in India, and we don't follow the DSM-5. we do follow the ICD-10. But psychiatry, unfortunately, is still very underserved in India because, we don't even cater to 10% of the population. I would have one question to Dr. Arshiany about what do you think regarding the use of biological therapies in the treatment of depression and bipolar disorder, especially the newer techniques which we are seeing, such as monoclonal antibodies and deep brain stimulation using of RTMS. So these are newer areas, but we don't have much evidence about that. So if you could comment on that, about the newer technologies which we are seeing.
Yes. Actually, we use ECT very, very frequently in our specialized psychiatric hospital. It's usually, we usually use it for a few indications. Psychotic depressions, which are very, very severe, we usually use ECT, and for pregnant patients too, uh, and for catatonic patients. These are the main indications we use ECT. They are very, very effective, and sometimes they do magic works. And RTMS is also used to, it's usually used in clinical practices, not in hospitals, not very much in psychiatric hospitals, at least not in the university hospitals. Is for private practice. RTMS is also used. It's quite, I can't say it's common, but it is used, and for different indications, for depressions which haven't actually responded to 3 or 4 trials. We use RTMS about quite 8 to 16 sessions, differing on the age of the patient, and they are actually useful and helpful. But relapses occur too. I mean, it's not like that. They're very different from medications. Like medications have relapses, they have relapses too. But they are used as substitute treatment, and mm, but other treatments, no, like VNS, we don't use it very, very commonly. It's not used, but RTMS, ECT, these are very, very commonly used here. For refractory OCD patients too, we use them too for RTMS and maybe sometimes ECT. I hope I've answered the question.
Yeah, I do have another question. If you could comment on the treatment of bipolar disorder in pregnant patients, uh, what is the special precaution one should take, and what therapy is advised with regards to
Sorry,
pregnancy?
I didn't understand the question. Can you repeat it from the beginning?
Bipolar disorder in pregnancy, what is the treatment protocol you would advise?
For pregnancy,
Yes,
bipolar disorder, yes?
yes, yes.
Bipolar disorder for pregnancy, well, during the first 3 months, if the patient is, it depends whether the patient is in a euphoric state or she's experiencing acute phase of the disorder. So if the patient is in a euphoric state, for the first 3 months, we keep her drug free and on psychotherapy. So maintained for the first weeks, months, the first trimester. And after that, we use lamotrigine if it's applicable, or atypical antipsychotics. Um, Lithium, valproic acid, and carbamazepine are never under any condition, only very, very specific conditions, which a few physicians, they consider it together, they consult each other. Only in very specific conditions, these 3 drugs may be used during the first trimester of the disorder, of the pregnancy, in an acute phase bipolar disorder. Other conditions, if the patient is stable, the first 3 months, she stays drug-free. After the first 3 months, she goes on atypical antipsychotics or lamotrigine. And if she experiences higher doses of atypical antipsychotics, may be used during the first 3 months too, in combination with psychotherapy. In very severe cases, ECT is the treatment of choice in pregnant patients.
Yes, thank you so much. I do have another question. We work a lot with infertility clinics and IVF centers. Now, many
Yes.
patients who are suffering from infertility, they have a lot of anxiety disorders, especially GAD, because infertility treatment itself is very stressful. Now,
Mhm.
post embryo transfer or post pregnancy, we don't give them any medication because most of the sedatives or SSRIs fall in category C or D. So, if you are getting a patient who is pregnant and is suffering from bipolar disorder or MDD, what would be the ideal treatment protocol for, yes,
Um, I didn't quite get the whole question. So you're asking that if a patient is a candidate for IVF and has a bipolar and mood disorder, what should we give him for anxiety disorders, right?
yes, yes,
Okay. Um, if a patient has bipolar disorder, IVF, non-IVF, the choice of treatment would be CBT for us. So because every anti-anxiety the first line of treatments, I mean antidepressants, we use it for anti-anxiety. So in bipolar patients, we can't prescribe these drugs. So the first line of choice will be CBT. But other drugs such as benzodiazepines, chlordiazepoxide, clonazepam, these could be used safely. Pregabalin, we use it very much, have to 75 milligrams, dose twice daily. We use it for anxiety symptoms very much. Um, Sometimes in bipolar disorders with anxiety symptoms, we can use a low dose. I mean, what we do is use a very low dose of SSRI in combination to an atypical antipsychotic. This is also a treatment that is frequently used. Um, was this the answer to your question?
yes, yes, yes. Thank you so much. Thank you so
You
much.
are, you are welcome.
Anyone else has any questions? You can ask the doctor. Okay, so I would like to thank Dr. Arshiany. We will have to end the session, but I'm grateful that she has come.
I've lost your voice.
Okay, can you hear me now? Hello?
Yes, yes,
Yeah,
I can hear
so
you.
I would like to thank Dr. Arshiany for conducting this webinar on behalf of CAV Foundation. We have had number of webinars before, and whether it's Dr. Victor Sanchez from New York or Dr. Enaki from Karolinska, they've had sessions. And today we've had mood disorder and bipolar illness by Dr. Arshiany. So I am very grateful to her, and hopefully we can have her again and conduct classes for our students and psychologists. And hopefully we can invite her to India for a conference and also help. She can visit our hospital here in Calcutta. So thank you, Dr. Ashiani, and that ends the session today.
You are very, very welcome. It was a pleasure and honor being with you. And sorry if I refer to DSM-5. I wasn't sure whether I should use DSM-5 or ICD 10 or 11. So sorry. And thank you very much, everyone. Thank you for your attention. Have a good day. Have a nice, beautiful day. Bye.